Actually, Sir, Dr. PK Jain sir has joined us actually. So, as you all of us know, he is one of the mentors, and he is one of the you can say the founder and founder president of Indian Society of Critical Care Medicine, the first president. And we are lucky to have our training programs under his care and to carry this forward. And this is one of the interesting topic what he usually teaches us in many of the sessions, and I think this is definitely going to change the practice for our new budding and upcoming intensivist in the future. And of course, our esteemed speaker today, Dr. Yes Javeri, so who has heartily accepted our invitation and means agreed to present out his own topic here. And he's basically acting as a director, critical care medicine and emergency medicine, Regency Health, Lucknow, India. And he's also a COVID medical task force member, the VP electives, the VP of the Vice President of Elect Society of Neurocritical Care, convener, Indian Sepsis Forum, and lot of many things to his credit. And we are fortunate, and I welcome to this great academic forum where all the blends of our DNB students, the IDCCM students, and the fellowships, they are able to learn something from these two eminent intensivists in India. So with this, I welcome Dr. Javeri to just present the talk, and please.
Thank you, Dr. Gunadhar. Thank you, Dr. Sapnil, Dr. Akhilesh. And we are privileged to have Dr. Jain sir for us in the meeting. So I will start my talk. The talk is about data interpretation in ICU. No conflict of interest for this talk. Data in critical care medicine. As an intensivist, we need to have a huge ability to interpret data. It's like a detective, Sherlock Holmes approach, we call it. We need to do a lot of clinical correlation. Data alone is nothing. We have to have numbers from the lab, radiological data, patient data, data from ventilators, CRT or dialysis machine, then correlate everything. Numbers alone do not count, but together with the clinical information, the clinical numbers make it countable. We need to recognize abnormal lab values. The reason for abnormal lab values, we need to have an eye to catch this data set. What is this data set? We'll go in detail in due while. Data in critical care medicine. We all understand stakes are high in critical care medicine. Most of the decisions have to be taken very, very fast, which means whatever data we have to analyze it. We have to analyze it very, very fast. There is almost minimum tolerance for error. Information often comes piecemeal, especially in the beginning while the patient is wheeled in the emergency or ICU. There is insignificant information. So whatever information we get at that time from lab data, from clinical data, or from radiological data, it has to be interpreted fast. So time in essential is less. Often, once the patient in ICU, there is information overload. We have a lot of lab values, we have a lot of clinical data, we have a lot of patient physiological data, and everything has to be interpreted. Most of the time, patients cannot give information on their own. That is why this data set is important. We often also talk about syndromic approach. As soon as the patient is in ICU or there is an RRT or code view, we need to recognize one major disease which has caused the crash of the patient. So we need to analyze it syndromically. It could be hyperkalemic cardiac arrest. It could be pulmonary embolism leading to cardiac arrest. It could be ARDS leading to hypoxia, whatever. So we need to have a physiological syndromic approach in the beginning. At times, we have a lot of data. We have big bundles of files coming to us. Diagnosis is often packaged elsewhere. At times, this is a blessing, but most of the time, if we stick to that and we do not think afresh, we continue to do the same. We do not change the outcome of the patient. So there is a lot of data in ICU. Most of our younger colleagues, they get drowned in numbers. They only treat numbers. But we understand we are not going to treat numbers. We are going to treat patients. Numbers can guide us, but it has to be taken with a lot of thought process going into it. The digitalization of healthcare system has resulted in deluge of clinical big data and has prompted the rapid growth of data science in medicine. Data science is the field of study dedicated to the principal extraction of knowledge from complex data, particularly relevant to critical care setting. Now, if we talk about a single patient, we understand there is huge amount of data coming in. We have history, we have microbiology data, we have lab data, radiological data, physiological data from the night or the day the patient is in, the history of the patient, what all treatment the patient has been taking. So what is important here? Treat the patient, not the lab measurement numbers or other numbers. Very, very important. However, why we have a patient who is crashing, the deteriorating patient, let the numbers do the talking. We cannot ignore the numbers always. At times, we have time to analyze these numbers, but most of the time, by virtue of our specialty, we do not have enough time to analyze. I'll give you an example. There is a patient with cardiac arrest. You do a blood test. Immediately after cardiac arrest, you find hyperkalemia. You have to treat hyperkalemia. Although it could be secondary to cardiac arrest because of acidosis and many other reasons. But at times, because the outcomes are time bound, we have to act very, very fast with limited data which we have. As Dr. Jain says, we have to act like a commando. Medical intensivist is a commando. We might have to go with limited information. Still, we have to fight the battle and win the battle. We have to act fast. We have to act with precision. So there is a lot of things which are at stake. Our lives as well as patient's life. Especially if we go for a code blue, for an RRT, we have very, very limited information. We are not at ease because we are out of ICU. We might be in the ward, we might go to a radiation suite, we might go to endoscopy suite. But time is money and we have to act really fast with whatever limited data we have. Tolerance for error is very, very low. Tolerance for delay is almost negligible. We should not delay. Information is piecemeal, not enough time, information overload, and we need to have data set. Data is the new gold. Initially, 15 years back, we had limited data. Physiological data which we had was only from the nursing chart. Whatever right or wrong, we have to believe it and we have to act on it. But now everything is computerized. We have recording of everything. We can have a snapshot of data from night. We can have snapshot of data for the last 7 days, whatever we require. So data is the new gold in ICU. And if we preserve this data nicely, this is real gold for us for clinical evaluation. Data in ICU can be broadly categorized as phenotypic or physiological. But there are many, many more parameters to it. Examples of phenotypic data include demographics, age, sex, lab values, physician and nursing notes. Whereas physiological data include common vital signs, blood pressure, heart rate, SVR, core temperature, and other parameters generated from bedside monitoring devices like ICP, intrabdominal pressure, EEG. Now, most of our ICUs have 24/7 monitoring and everything is digitally recorded. That is why we have a huge information now which is coming to us. In a sense, environmental data, medical data, genomic data, there are many, many more parameters to it, but we'll stick to the basic data. How does this data flow in the intensive care medicine? We have to understand the data which we are analyzing and basing our care is dependent on the end collector, the nurse or the duty doctor who is taking the data, or your monitors, how precise they are. So whatever data you feed, the same data you are going to analyze or somebody else is going to analyze. So we have to be very, very vigilant that the entry of data is right, whether it is nursing note, whether it is computer generated, whatever, because garbage in, garbage out. If we feed wrong data, we are going to analyze and base our treatment on this wrong data. So data quality is important. It is more so important while we analyze our quality parameters. Like most of the ICUs, the catheter-related bloodstream infection rate is always 0. But is it true? No, it is not true, because our data quality is poor. We do not feed the right data. Data interpretation has to be very, very precise. If we are talking about patient clinical care, then it has to be fast. It has to be corroborative. We all understand man behind the machine is important, not the machine. That is why what is fed to the system will decide what is the analysis. We have e-access to complete and accurate information 24 hours. We also have to look at data privacy, documentation, and document preservation, whatever ways you want to do it. Sir Peter Safar, critical care is not a location, it is a process. It takes place not only in the ICU, but everywhere. That is why we have more and more data which is coming to us. Many of our hospitals now have medical emergency team triggers from the clinical data. And most of our decisions are also based on this clinical data. Now we have e-access to clinical data. Patients at home who have been discharged from home, they are also being looked with hardcode data from the ICU or from the ICU offices. So critical care has widened its horizon thanks to the e-ICU concept and electronic collection of patient data. That is why we are able to move on to smart hospitals. Artificial intelligence is already there. I was heading to a digital conference 5-6 years back. Somebody asked whether this AI is going to replace the physician. There was an expert from Netherlands. He answered, no, AI is not going to replace the physicians, but those who have learned how to use AI are certainly going to replace those who haven't yet started using AI in their clinical practice. So if we like it, we don't like it, we have to use AI in our clinical practice. And most of us, knowingly or unknowingly, are already doing it. When you write a computerized prescription, it will prompt you, this is interaction with this drug. Most of our microbiological data is correlated clinically thanks to AI. It will correlate with your antibiogram, what cultures are growing in microbiology, and what drug you are prescribing. So there's a lot more to it. We saw how AI generated algorithm worked for COVID radio diagnosis and a lot more to do. So more and more systems, especially the CPRS system, are using AI to a big extent. Data is must, but we should not be drowned in data. You can't see the forest through the trees. So we have to have a wider horizon to see what really matters to us. The problem is too many tests, too much reports, too much data, different names of tests, different units. So there's a lot of confusion, different reference intervals from different labs. Again, we saw during COVID, different alert limits because the reference intervals are different, units are different. And the guidelines were also a little hazy at times. So whatever data is coming to you, first thing you have to look at is the unit and the reference intervals before you analyze it. Another important thing is, before ordering a test, we should know with certainty that what are you going to do, if it is positive or it is negative. Before ordering a test, decide what you will do if it is either positive or negative. And if both answers are the same, then don't do the test. Don't over investigate. Most of us are in habit of doing it, but we should change our habits. We should know the reference ranges, unit. You should know turnaround time, whatever clinical data or lab data you are asking for. Like CPK, most of the hospitals, the CPK turnaround time is huge. Leptospira IgM, many small hospitals, they get after either the patient has improved or patient has died. Cost of the test, factors influencing the result, clinical interpretation, or further investigations required, and delivery of results. Lot of data. This is from a single patient. If you want to analyze, it comes down to at least 10 to 12 files for any 7 to 8 days stay of an ICU patient. So clinical correlation is very, very important. You should know your patient. You should know the clinical history. Then only you analyze this lab data or radiological data or physiological data. If you get a report which is out of range, the first question you should be asking is, does this belong to the same patient? Is it real, or there is pseudo hyperkalemia, pseudo hyponatremia? Is it fitting clinical picture? The ECG is normal, patient is passing urine, there is no clinical context for hyperkalemia, still the patient is having hyperkalemia. So you have to think hard. Is it dangerous? The most important question is this. If is it dangerous, is it life threatening? If it is life threatening and you have some more physiological correlation, you have to act immediately and treat the cause. And you have to look for coexistent abnormalities. We have to monitor the trend serially and long term, and we have to look for recurrence. Say we talk about hyperkalemia, hypoglycemia, we have to look for recurrence. Acidosis, once you have tried to rectify, say with sota bica, you have to look for recurrence. If it is recurring, you might require CRRT or dialysis or whatever. So these are important questions you need to answer when you have a report which is out of range. It's a critical lab alert. Critical lab value reporting is there in all the hospitals. It is immediate notification of a critical value. Critical value reporting is essential to ensure quality of diagnostic lab services. And JCI NABH, everyone mandates that we should be having a critical alert. Critical alert should be reaching the end user, the frontline healthcare worker, the doctor on duty. Most of the time, it goes only to the physician in charge. So now, 2 a.m., you have a patient who is having 107 of sodium and patient is seizing. And the doctor on duty does not know, it's just like a message on your mobile. So you have to have a system that it percolates down to the patient care site also. From a typical ICU round, we generate a lot of information. We already discussed this. History, examination, systemic review, equipment, blood gas, intake output, biochemistry, pathology, hematology, nursing charts, microbiology data, radiological data, electrolytes, ventilator graphics, and whatever else we document. There's a lot of information which is provided but not used. We all have seen this while we analyze a death or an unfavorable outcome. And when we start reviewing the reports, reviewing the file, we find out, oh, we missed this on day 3 and day 5, we had this unfavorable outcome. So we need to pick the right information. Lack of time is one big factor. Other big factor is too much of information. That is why we have to filter down what we require. If we over investigate, obviously we'll have more data. So we have clinical wisdom to have limited data with us so that we can analyze what we have. Lack of training, data interpretation is seldom taught in any of our curriculums. Power of observation. Sadly, this is a lost art now. Nobody wants to observe, only numbers matter to most of the people who are working on the ground now. Correlation and interpretation of data, very, very important. So we look at numbers, we analyze numbers, but this clinical correlation and power of observation is we are losing. There are very many reasons for erroneous results. It could be specimen error, it could be transcription mistake, wrong patient, wrong report, prolonged tourniquet time, which will increase protein bound substances like calcium, protein, albumin, drug levels, total thyroxine. Non-fasting venous specimens, postprandial hyperlipidemia, hyperglycemia, sampling from the drip arm. It can lead to artificially high or low values of sodium, potassium, glucose, APTT, and serum drug levels, depending on the content, what IV infusion is going on, and what is the degree of dilution or contamination, whatever you want to call it. So drip arm sample depends on what infusion is going on and what you are analyzing. Pouring over between containers with different preservatives or anticoagulants. Potassium EDTA contamination increases potassium and decreases calcium and alkaline phosphatase. Sodium citrate contamination, high sodium and low ionized calcium. Failure to ensure separation of plasma within 6 hours. Obviously, hyperkalemia, increase LDH and phosphate, decrease glucose and bicarbonate. And this is a common thing which we see in our practice. Traumatic collection of blood specimen, hemolysis, potassium will be high, LDH and phosphate will be rise. So there are many reasons for erroneous results. We cannot go in detail in each and every one, but what we have to understand, the reasons for erroneous results, and whenever you have a report in your hand, you have to just scan through it whether the report is authentic or not. Confirm the patient, confirm the timing. It has happened. We ask for potassium, we think, oh, still potassium is 7 in the morning, while this was 1 a.m. report, same date, and you have already corrected, and you overcorrect potassium. Recheck, resend if there is any doubt. Utilize point of care testing. Correlate with clinical picture and other investigations. Look for consistent coexisting abnormalities and data set and syndromic approach. I am repeating this again and again because it is very important. Okay, we'll go to some data sets. Thank you, Jain sir, for teaching us this again. 47-year-old male, long-standing hypertension, admitted for arthroscopy. This is his biochemistry. I will like the students to answer. What is the likely cause of this biochemistry? Sodium is 116, potassium 7.4, chloride 85, bicarb 25, glucose 6, urea 11, creatinine 0.12. You can type on the chat box. Any answers? Okay. Another patient. We'll analyze 3 cases together after this. No, not concentrated sample, Dr. Mayur. Let us go ahead. 56-year-old female COPD admitted with chest pain. Day 3 of hypotension, 70 by 30 millimeter of mercury, not responding to fluids or inotropes. See, you can pick up these abnormalities. Hyponatremia with hyperkalemia. Bicarb is 18. Osmolarity is 271. Glucose is 3.1. What comes to your mind? This is hypoaldosteronism. Dr. Nishant, very good. So this looks like an Addison's. Another patient, same patient. COPD patient, 56-year-old, day 3 hypertension, not responding to fluids or inotrope, likely cause of hyponatremia. We'll go on to the cases now. So this data set you have to recognize: hyponatremia with hyperkalemia. What could be the causes? It could be DKA, early renal failure, adrenal insufficiency, ACE inhibitors, potassium-sparing diuretics, NSAIDs like indomethacin. So what is a data set? The finding of multiple test abnormalities which observed together should prompt consideration of a specific diagnosis of differential diagnosis. You can call it a syndromic approach based on lab data, or it could be just a clinical acumen what we're developing. 47-year-old male, long-standing hypertension, admitted for arthroscopy. Following is his biochemistry: sodium is 116, potassium is 7.4, chloride 85, bicarb 25, glucose 6, urea 11, creatinine 0.12. So answers here. What is obvious? This data set is obvious. Hyponatremia with hyperkalemia. And what is another gross abnormality? You can see the urea is raised, potassium is, the creatinine is also raised. So this could be again ACE inhibitors, potassium sparing diuretics, or NSAIDs. 56-year-old female admitted with chest pain, day 3 of hypotension, not responding to fluids. We already saw this. Bicarb is 18, glucose is 3.1. And somebody already answered, this is adrenal insufficiency. Hyponatremia, hyperkalemia, acidosis, hypoglycemia. So this metabolic acidosis and hypoglycemia combination should alert you towards hepatic failure, alcohol intoxication, seizures, metformin or paracetamol toxicity, quinine, salicylate toxicity, mixed edema coma, severe malaria, or protein calorie malnutrition. Then you have to look at your clinical context. What fits into this picture? 40-year-old admitted to your ICU. RRT is announced for critical lab values. Sodium 110, potassium 2.9, fluoride is 80, osmolality is 291, glucose is 68.02 is urea, and 0.04 is creatinine. What does it look like? Anyone will like to answer? And we see such reports every now and then in our ICUs. Anyone? This is a drip arm sample. This is with dextrose. 28-year female, because all the levels are low. And you can see dextrose, so glucose is 68. So this is a drip arm sample with dextrose. A patient in post-ictal state, 28-year-old female, brought to ICU, epileptic, on carbamazepine, but not taking it regularly. So this is the clinical information we have. Sodium is 113, potassium is 3.5, urinary sodium is 40, bicarb is 24, serum osmolality is 245, whereas urinary osmolality is 549. Glucose, urea, creatinine are in normal range. So what is the clinical picture you are looking at? Yes, Dr. Nishant, wonderful. So this is SIADH. Why is this clinical diagnosis right based on this lab data? Because this is drug-induced SIADH, because patient is on carbamazepine. There is hypoosmolar hyponatremia. Osmolality is 245. Urine sodium is more than 40. Urine osmolality is more than serum osmolality, 549 against 245 of serum osmolality. Normal adrenal, liver, thyroid, and cardiac functions. No acid-base abnormality, normal potassium, absence of hypotension, hypovolume, and edema to define SIADH. Another female patient, 58-year-old lady, complains of lethargy for 2 months and some weight loss. This is her biochemical report. Sodium 115, serum, urinary sodium is 42, potassium is 6.8, chloride is 84, bicarb 20, glucose 3.4, urea 13, and creatinine of 0.1. Anyone will like to answer this? Again, this is a case of adrenal insufficiency. 15-year-old girl brought unconscious to ICU, history of lethargy and breathlessness since 10 days. She has history of diarrhea since 3 days. Sodium, serum is 123, urine is 86, potassium 7.8, serum, chloride 106, bicarb 4, osmolality, urinary osmolality is 678, glucose is normal, urea is 18 in serum, creatinine is 0.5. ABG, pH is 7.06, PCO2 36, PO2 of 84. So creatinine is 0.5, whereas urea is slightly raised. There is hyponatremia, hyperkalemia, and severe metabolic acidosis. What can you find here? Low urea creatinine ratio. Again, this clinical data you should not miss. It could be diabetic ketoacidosis. What are the other causes? Rhabdomyolysis, cephalosporin, cimetidine are some other causes, but you should not miss this data set. 58-year-old man undergoes exploratory laparotomy for DU perforation. ICU day 5, patient is tachypnic, failing spontaneous breathing trial. Sodium 139, potassium 3, chloride 97, bicarb 27, glucose is 6.8, urea is 2.9, creatinine is 0.04, magnesium is 0.6, serum magnesium, phosphate is 0.3. Anyone will like to answer? This is an easy one. Yes. It's Dr. Nishant. Perfect. This is a case of refeeding syndrome. profound hypophosphatemia, hypokalemia, hypomagnesemia. Now, if you have this triad, hypocalcemia can be also there. You should think about refeeding syndrome in the right clinical context. Usually occurs on day 3, day 4, multifactorial, carbohydrates, especially IV glucose, intracellular shift. How to prevent it? Start slow feeding, supplement potassium, magnesium, phosphate. And the right subset of patient, you have to have an eye and measure these electrolytes serially so that if there is refeeding syndrome happens, you diagnose in time. These are the 6 Ds for hypomagnesemia: diet, malnutrition, malabsorption, diarrhea, diabetes, drugs like diuretics, aminoglycosides, delirium tremens, and data set again, low potassium with low calcium. You have to think about hypomagnesemia and check it and correct it. Few more data sets. Now, these data sets are from pathology. Mrs. JS, 42-year-old male admitted with Mr. JS, 42-year-old male admitted with fever and septic shock. This is his hemogram. Hemoglobin is 9.2, WBC of 2.9 thousand, platelet counts of 56,000, neutrophils 0.1, lymphocytes 1.2, blast cells are very, very high, units are different. So what is this diagnosis? Dr. Nishant, perfect, bullseye. This is AML because the blast cells are there. Normocytic anemia, neutropenia, and thrombocytopenia, numerous blast cells. Again, this data set, you have to diagnose it. Mr. KS, 42-year-old male laborer. This is the hematology report. Slight anisocytosis, slight poikilocytosis, occasional spherocytes. Neutrophil showed a marked shift to left and toxic changes. Band 5.1%. So this is normocytic anemia with neutrophilia and lymphopenia. This patient has subhepatic abscess in a malnourished patient. So at times, the diagnosis will not be obvious. So you have to think about it. There is some infective pathology which is going on in this particular patient. Mrs. HL, 54-year-old female, admitted with shock, fever, and flank pain. Midstream urine microscopy, polymorphs 200. No cause detected, no bacteria seen, culture revealed Pseudomonas. So this is Pseudomonas bladder infection. Another patient, 64-year-old female, admitted with pain, abdomen, and distension. Peritoneal fluid, microscopy 800 cells, polymorphs. Occasional RBC, occasional GNB. Culture, moderate growth of E. coli, light growth of bacteroids, scant growth of Enterococcus. Hello. So this is peritonitis secondary to gut perforation. WBC counts of more than 250 should point out towards peritonitis. Growth will always reveal a mixed enteric organism. Last data set, 24-year-old male, headache, fever, vomiting, and altered mental status. CSF glucose is 24 mg/%, protein 260, WBC 1200, which are predominantly PMN, and opening pressures while doing LP. And the gram stain, many gram-positive cocci, mostly in pair. So what is it? Gram-positive cocci in pair with a picture of pyogenic meningitis. This is pneumococcal meningitis. So this is pneumococcal pyogenic meningitis. What is important here is, in critical care, data is critical. The scale of data collection has given rise to big data and the field of data science. But we have to be realistic. We should think about big data, we should analyze big data, but we should not be in a statistical jargon with patients. We understand data-wise, evidence-wise, by SMR rates, the mortality will be this or this. But the statistical jargons will not always be right. It depends on patient to patient. We understand there are many factors for a good outcome. So whenever you apply this big data to patient care, you have to be very, very judicious. You have to be dependent on many, many factors, the clinical trends, the lab data, and many other important informations. Lastly, check for correctness of data, whatever data we are talking about. Correlate clinically, communicate. If it is out of range, if it is life threatening, communicate loudly and clearly. We have to recognize this data set so that we are faster in our diagnosis and we do not miss important diagnosis. Syndromic diagnosis based on clinical data, lab data is very, very important. Lastly, recheck, recheck, and recheck. Thank you.
Thank you, sir. Thank you for the excellent presentation. So to continue the discussion, we have with us PK Jain sir. So whom I can describe is one of the mentor and founder of the data interpretation in clinical medicine and critical care. So I welcome sir. Sir, any take from your side regarding the new intensivist, how they should approach a patient in critical care unit?
Yeah, thank you, Gunadhar, for the kind words, and it's nice to see Yash, who's I'm very proud to call a friend, wonderful teacher there. And yes, data interpretation is very important. I'm also happy to see Nishant, who is a past student of the FCCCM of the College of Critical Care, and I'm sure that training helped him pick up a lot of these right answers. So, which is very nice. Knowledge, it's nice to spread knowledge. So it's as Yash pointed out that, there is a sense of urgency in the intensive care unit, and this data set approach, the Sherlock Holmes approach, allows you to save time and quickly narrow down the differential diagnosis, and then you use your clinical judgment to make your priority list there. So it was a very good topic, and that's why I was very keen to attend. It was lunchtime and I could attend from here. So I'll probably attend more, that now that in 15 days I'm coming back to India, and then I'll be there for 6 months. And so it'll be easier for me time-wise to attend.
Yes, sir.
There. So,
yes, sir.
Great.
Because if so far I remember, sir, you have a vast set of data set actually, which is there.
Yes, it's mind-boggling. Yes.
So and this course actually, which is one of the, I can say, the founder course, and every student should undergo when they are just jumping into the ICU and starting their new career. And actually, it will help them to build the founder stone in critical care medicine. So,
very, very true.
So if we could like to have one of your sessions, and
Sure.
in the subsequent programs, it will be a
Sure. Definitely. We will do that.
Yeah. Thank you, sir. Thank you.
Thank you.
And would happy to take some questions. I think most of the DNBs and the fellowship students are here. So anybody who is like to put any questions in the chat box. So sir is there, Jain sir is there, Dr. Javeri is also there, and we can discuss. Otherwise, just to carry the discussion a little bit more extensive. So I request Dr. Javeri. So whenever the patient is in the ICU, so and the patient is critically ill, so these data sets definitely help. But is it these data sets are enough, or there is something beyond this data set that the budding intensivist should know to approach a patient?
Very important question. See, whenever you approach a patient, obviously when we talk as intensivist, patient is seriously ill, we need to have a multi-pronged approach. We need to look at the patient first and foremost, do the physiological stabilization. The most important thing is physiological stabilization. Diagnosis, especially at the beginning, might not be important at all. Suppose a patient is hypoxic, you recognize it from your monitor, from your ABG. The first and foremost thing is to rectify it. Once you have stabilized the patient physiologically, then you look at the cause of disease and then do the root cause correction. However, the basics should always be stick to. The clinical data is first and foremost. Most of the time, while you take history, you will always have a working diagnosis, and 90% of time your working diagnosis will be right. If you jump guns, straight away do a ABG or straight away start doing SVR, obviously you have a fixed mind and you are trying to find that diagnosis. That should not be the approach. You should arrive at diagnosis, and we should have a principle of parsimony. We should not be having 5, 6 major diagnoses in mind. We should have one single diagnosis in mind. Often we will have some differentials, but we should work towards a single diagnosis, especially after stabilization of the patient. The labs which you are sending, or radiology or whatever advanced hemodynamics you are using, should be dependent on the patient requirement. Not all patients will require a similar workup. And when we call it routine lab set or routine radiology, this is wastage of resources. So nothing should be routine, not even a CBC or an ABG. It should be dependent on patient's need. And once you have your clinical data, then only you formulate your final strategy. However, the clinical data you gather gradually. Now you have to understand, some patients you have to be very, very fast. Like suppose you have a patient, a young patient who have pneumonia, and you have a renal transplant patient now who has pneumonia. You might need to do a more detailed, faster workup for a patient who is immunocompromised with pneumonia as against a healthy individual with pneumonia. You might overdo in such patients, like you molecular diagnostics for diagnosis of microbiology and henceforth. So it should depend on the clinical context, what all data you are trying to gather. Do not have too much of information. Look at the basics. Do not do routine labs. And if some important lab parameters is out of range, it should be communicated to the team. It should not be lying in your mobile or as a critical alert. That is it. So you have to look at clinical parameters in conjunction with the lab parameters, and then draft your protocols according to the numbers.
Very well said, doctor. It's a very different actually. Thank you very much for the update. I have one question in mind, and we often see, like, we have different devices for laboratory monitoring and all that. Nowadays we are more dependent on iStat kind of immediately available diagnostic tools, iStat and all that, which gives you instant results, whether it is TROPI or whether it is any kind of electrolyte or ABG or whatever. So, but we find a lot of discrepancy between these iStat values and the real laboratory values that we get in from the lab. And we often see that there is a discrepancy in the readings in the different days as well. Like if you see Sundays, you will see that their labs are not reliable. Okay, most of the times you will ask your doctor that you will please don't do much labs on Sunday. These electrolyte reports or whatever, some tests may not be reliable. So how do we take care of such events, and how do we find out the discrepancy, and how do we have a corrective measures? So now, as you said, the data collection is so important. Okay, and then if we have such discrepancies, then the data may be false, and then the interpretation of the data also becomes very difficult in such time. How do we take care of this? My question is to you also, and Dr. Jain also, sir. Please throw some light on this. I think my question was too long, but I hope you are able to get it. Yeah.
Let sir answer first.
Akhilesh, hi. It's a difficult question to answer because throughout India, from top to bottom, left to right, clinicians have this feeling that lab data doesn't correlate with the point of care data, and I really don't know the answer to this. Ideally, in an ideal world, it shouldn't be different unless you're using different technologies. Because if you're using, say, an electrode analyzer, sodium electrolyte or blood gases, they shouldn't differ. But if you're using a flame photometer in one place and you're using an electrode analyzer, yes, there can be a discrepancy. Second is, are you using whole blood in one place and are you using just the plasma in one place? Then you can get a difference in the readings there. Apart from that, we tried in a hospital where I was affiliated with for a short time in Delhi for 1 year. We kept on sending samples, the same sample divided into two to place, and we weren't getting differences. But yet, when we weren't there, the residents would say there is a difference occurring. So I really don't have a better answer to this. I think we need to see whether the diluents being used in the lab and what are they doing there. I tend to trust my own data. If something is in the ICU and we've done it ourselves, I tend to believe that more because things are under control. I know what the diluent is. I know what method we've used, whether we used whole blood or plasma, etc. And in the overall picture, the differences may not be all that clinically significant in terms of when you use them for replacement. Now, if you get a low sodium, in one you get 123, in the other you get 118. I know that we think it's a significant difference, but even when we start correcting, we have no control at the rate on which it is getting corrected. We still have to measure and see how it is improving. So that's about it. I'm eager to listen to Yash also on this, and all of us. I mean, Gunadhar is a Pandit in critical care, and so are you, Akhilesh. So, and there's so many other people in this group. Yash, what do you say?
Yeah. Sir, my take would be we are overdoing it most of the times. We saw during COVID also. We overdid everything. We overdid radiology. We overdid biomarkers. We emphasize a lot on investigations. Like my previous hospital, we will be very, very wise in choosing our test. Even if a younger, fresh consultant says, "Why are you doing it? Is it required?" Every test we used to ask each other, and at times we did not do CBC say for 5-7 days. But most of the ICUs, the practice is like routine lab, whatever reasons are to it. But I think we should stop it. There's a lot of wastage. There's a lot of pain. We understand there is iatrogenic anemia because of unnecessary testing, unnecessary radiology. Patient is getting exposed. Not only patient, the number of X-ray ICUs, X-rays in ICU expose everyone to radiation. So we have to be very, very choosy with our investigations. And with advent of ultrasound, and our X-rays are much, much less now. Labs, we are trying to be judicious and try to decrease our tests. What we do is every 5th or 7th day, especially if the patient is a long stay patient, every 7th day we try to get a complete data. However, for a short stay patient, some lab we get it daily, but not all the labs yet. We try to move towards a minimalistic, but second problem is patients. They also put a lot of emphasis. They will ask, what is the creatinine today? Why did you not do a post dialysis urea creatinine? So there are many, many factors, but we certainly do a lot more what is required for patient, and this is a wastage of resource, sir. How to stop is very, very difficult. Another important segment where we overdo is biomarkers. Like procalcitonin, some people are in habit of repeating procalcitonin every 3rd, 4th day for escalation, for de-escalation. And we analyze some of the files. One patient procalcitonin was done 20 times in 45 days. So it's a huge cost also which is coming down to the patient. How to decrease it? We should be very, very judicious, and probably there should be some wisdom. And the lab should ask, why do you want to repeat it daily? But again, it's a revenue matter and numbers for them also.
Yeah, no, I agree with you absolutely. I mean, whatever investigations we do, I think it should have some clinical justification.
Yeah,
Any change in patient's condition, and if
absolutely.
it is, justified, then probably we should do it. I think there are some other factors like, reagent related issues, cartridge related issues, how old is the cartridge, how frequently the cartridge has been used, or how frequently the reagent has been changed or something like that. I think, and there is subjective variability as well, actually, how the sample is being processed, how the sample has been handled, where the sample, if we have collected the sample and processed after a long time, probably that values also will be different, and if you do it immediately, the values will be different, probably. So these are some of the things I think we can critically analyze. What is the process of collection? How much is the sampling, processing time, and how much is the interpretation time? So it matters a lot, and there is a lot of variation amongst clinicians. And like you're looking at the slides, and you're interpreting the platelet count sometimes, or WBC count. So that also varies. I mean, probably, and these factors also should be taken into consideration while we analyze the test. Like if a junior most person is analyzing a hemogram on a Sunday, probably that will definitely give us a value which we may not be expected at times. And at the same time, as you rightly said, like you and Sarah has also rightly said, like whether you're collecting your sample and processing it from plasma or from whole blood or something like that. So these factors are also very, very important, and I think we should have analysis. Like in previous setups that we were working, we were not relying much on the Sunday samples. Okay, and the Sunday samples, I mean, you also must have had some experiences of a similar kind. Like the samples which were processed on Sunday were showing erroneous results, and then we have stopped sending samples. But yes, the clinical context is very important. It should be justified, and then it has to be taken into consideration as how the trends are. And we should be very minimum and judicious with doing investigations. You said rightly, we are doing overdoing with the investigation. Probably that should stop. Yeah, you wanted to say something?
No, absolutely right. Actually, what's
Yeah.
actually the focus, what I realized is changing from more and more investigational approach to the clinical approach. So the ideally the reverse should be carried out in any good critical care unit, and high sense of clinical acumen actually, which is the basic key for the diagnosis. And based on the diagnostic suspicion or the proper diagnosis, then only we have to see whether the data can actually change the guidelines or change the management, or it will make some difference to the patient's outcome. But now for all these juniors and all, they are more and more relying on the data and numbers rather than seeing the patient and actually touching the patient. So I always remember, sir, when he used to say that the bedside examination is one of the best examination, which can give you a clue of almost in the range of 90% with very less accuracy, and diagnostics are always supportive. So that is what actually I can able to say here.
Yeah, I agree with Dr. Gunadhar. I mean, we are more gadget free, and we love gadgets, and I think we are not spending much time with the patient. I think the practice should change from the investigative modalities to the bedside assessment, bedside clinical tools are better. These investigations are just additional tools which may help you, but I think we should old days practice where we used to have a tender love and touch to the patient. By simply touching the patient, you can get a lot of information. Dr. Jain always used to say, touch patient, you will get n number of problems that you will be able to elicit from the patient. So I think let us be bedside, let us touch to the patient and offer the tender love and care. Probably that will help you avoid investigations also, and you will be able to analyze the patient when you're spending time with the patient. So that is lacking probably, and I think we should focus on that as well. Yeah, so there should be a data collection on this as well, like how much time you spend on a clinical examination, and what is the data that you get it, and how many times you can avoid doing the investigation. Probably that will help us, to analyze our own data, whether we should be data driven or clinically driven. I hope so. Yeah. Any other questions in the chat we can take?
Sir, there's a question in chat box. What's your opinion on artificial intelligence used in ICU? Will AI help us analyze this big data and probably improve outcome? Second one is from the same Dr. Nishant. Like Chat GPT, can there be a database for critically ill patients, and can it be practical future application?
Yeah, I think Jain sir can take this.
Yeah. Am I audible? I don't know if it's, yeah, I am.
Yes, sir, yes, sir.
Yes.
Yes,
You see, I have done work in artificial intelligence along with 2 PhDs from the computer division of BRC many years back. And that was when computers had just come in to the hospital, and I did little artificial intelligence programming. From wanting to computerize the ICU, within a year, I switched to not wanting to computerize the ICU because what I feared was it'll take away the human element. You see, all that you can see on the monitor is tachycardia, but when you are next to the patient and you see sweating on the forehead, that tells you that something is very seriously wrong. Or look on the face of the patient, whether he's in pain or not, can give you more information, because tachycardias are very non-specific and tachypneas are very non-specific. Do you understand? So that's one thing. The technology, will it ever do good? I don't think so. Even Chat GPT, you see, I don't know if you came across this. You can convince in one particular session Chat GPT to start giving you wrong answers. If I say the sky is black, Chat GPT will say no. But I will say no, it is. It will start accepting the sky as black. Okay. And therefore its subsequent answers will. If I say 2 + 2 is 6, while Chat GPT initially will say no, that's wrong, it can be made to accept it as right and subsequently to start deviating. You shut off your computer, you start again, Chat GPT is back to normal. But so these technologies can be fooled, all right? And in healthcare, it can be very dangerous to have these deviations. Blood gas electrodes, they drift, and therefore you start getting errors, okay? And so nothing like the human mind. And then if we stop using our mind, we will start degenerating, all right? The reason we're improving and evolving is because we're using our minds with new ideas, new thoughts. We're going into space. We're doing a lot of things. And I think intensive care is interesting because all our senior colleagues will tell you, because when we use our brain and we solve a problem and we can catch it, the joy it gives us makes intensive care very attractive. But if it's going to be artificial intelligence, if I'm going to feed in the details and it's going to tell me, the intensive care practice will become the most boring practice, because you will stop using your mind and then you will start listening to a machine, which can grossly go wrong. There is no right answer. I mean, even in critical care and in medicine, there's no one way to skin a sheep, so they say. So the beauty of critical care is you can reach the same results by slightly different methods. Your antibiotic choices may be different for the same patient. The patient still will come out of it. So no, I am in fact dead against artificial intelligence replacing the human thinking. But yes, to allow it to do some sort of interpretation and narrowing and monitoring use of artificial intelligence may seem attractive, but not to replace the intensivist. Sorry
Yes,
if
sir.
it was a little lengthy. Huh?
Absolutely, sir. Absolutely. And also, Dr. Javeri has already told that it's a garbage in and garbage out. So it's all also depends on how you feed the data in the artificial intelligence system, basically, and how it captures and what is the internal processing system. So sometimes the wrong data might be fed, and it can be sometimes be dangerous for the patient if the machine is not working properly. So that is also another drawback, possibly.
These machines also needs to be monitored by human brain. So we can't be completely leaving it on the monitor computers, and doing the task. Whatever the algorithm we set, we'll have to monitor the algorithms also whether they are processed properly. Definitely, these
Akhilesh,
artificial intelligence have helped us to.
in
Yeah,
1990,
artificial intelligence is
in 1990, with 2 PhD students, we put almost the whole of medicine into an artificial intelligence program for purpose of diagnosis. And we took that Golwala's textbook of medicine and we computerized. So if you said, I have got cough, the computer would ask you, is it wet or dry? And if you said wet, it would say, is it blood tinged or not blood tinged? Is it white, yellow? So it would ask you for more information and then draw conclusions, which wasn't very difficult because it's like, I'm thinking of an animal. Is it got 2 legs, 4 legs? If you say 4 legs, is it got hoof or not? Can it fly or not? And you can then narrow down to what the animal is. But what may happen is, and especially in developing countries, is you'll have quacks using it or unqualified people, untrained people using this and treating people. So, and they can never replace the trained intensivist.
So, but sir, I think with the help of artificial intelligence, we can take the advantage of, interpreting the result. Dr. Zaveri has given us so many examples, where the data interpretation, it takes some time for us also to calculate several values and come up to a conclusion and get a diagnosis. Like if you want to diagnose renal tubular acidosis, whether it's type 2 or type 3 or type 1, or if you want to diagnose
Akhilesh, I'll tell you one thing. Most of the new
This
ECG
data
machines
is-
have an artificial intelligence where they give you an interpretation. Okay. And I can
but
tell
then
you
sometimes
that all over the world, 90% of the interpretation by the AI in the ECG machines, smart ECG, are wrong. Okay. And that is
Yeah.
why you cannot rely. There is artificial intelligence interpreting the ECGs. And if you listen to from Mayo, the Amal Mattu's experience, he's like the god of ECG. 90% of the time, the ECG interpretation is wrong. He says, don't even look at it because you'll be biased. Yes, if you want to see the QTC corrected, yeah, it'll do the calculation and you don't have to do it. But interpretation, no. No one today trusts the ECG interpretation by a machine. That's artificial intelligence for you.
Yeah, so it cannot replace human brain.
And the blood gas analyzers also have so many of them have interpretation coming in. How often is it wrong? Because we are not feeding the FiO2 into it. Very often, patient is on 50% oxygen and we just feed the blood gas. It comes as room air and the alveolar arterial gradients are wrong. Everything is wrong. So if the junior doctors start looking at that interpretation, where would we go? Because as Yash said, garbage in, garbage out, we're not putting the FiO2 inside. So how can the alveolar arterial gradient calculation be correct?
Okay.
Yes.
So definitely this factor should.
What is your only means? I can say the take home message for the all the newcomers and budding intensivists who are coming to critical care, sir. In
interpreting the data.
In regard to practice and interpretation and data analysis.
Whom are you asking? Sorry.
Sir, to you, sir.
To me. Can you just message? Where is the role of data interpretation into this? Yes, I think every young doctor entering critical care should know about it and should know it. I mean, that's why he can use it anywhere. He should know. And data sets or the Sherlock Holmes approach is not just to blood reports, it's to ECGs, it's to X-rays, it's to every aspect of critical care. There is a data set. Data set is just 2 or more abnormalities which often don't occur together. All right. And that makes it attractive. that makes it beautiful there. Imagine we do away with all the detectives and Sherlock Holmes and just let the computer analyze who is the culprit. It would give us a wrong this thing. I think it makes it interesting. It's and therefore they should learn it definitely. No options. They need to know it.
So, Swapnil,
Yes, sir. I will conclude, sir. Before that, I request all of our students, if there are any question, can put in the chat box or can ask directly. Otherwise, this session is being recorded and it will be on our YouTube channel, which I have already provided the link. Probably in a couple of or probably 1 or 2 weeks, it will be on the YouTube channel. What we are, I already mentioned. So to conclude this thing, I will just say that artificial intelligence is to make our life easier, but we cannot depend on it. Ultimately, our presentation point of view, I'm very thankful to Dr. Zaveri sir and Dr. Jain sir to show up, and it was our fortunate thing that we are able to see you after a long time. So I will not waste lots of time, and I will be very, very thankful to all of the my seniors, and I look forward to continue all these academic sessions, which will be much fruitful and helpful for all the students preparing for all kinds of exam. Other than that, it will always improve our clinical practice, and we should go ahead with the excellence practice in critical care medicine. Thank you very much, sir. Thank you very much once again, Gunadhar sir and Akhilesh sir, and everyone who has attended and showed to the academic session for today.
thank you, sir. Thank you.
Yes.
and-
Bye.
Nice
Bye,
meeting you,
Akhilesh,
sir. Long
Gunadhar,
time.
Yes, sir.
Swapnil.
Bye-bye.
We'll see you, sir, whenever you are in India. After
Yeah,
six
I
yeah,
will.
Nice
Nice.
meeting you. Catch up.
Have a good day.
Thank
Bye-bye.
you, sir. Have a good day.
Bye bye. Good night.